Hello, everybody. This is Dr. Kashif Abdullah. It is May 14th, 2020, and I'm talking to you about. Today I was thinking of talking to you more specifically about hospice, since I'm a medical director for hospice, and also I thought I'd talk to you about the COVID-19 situation. I'll start off with the COVID-19 situation. Actually, you know what? Let's talk about hospice, actually. Uh, so, in regards to hospice, let me show you. Okay, what is hospice? Let me first of all tell you what hospice is. So, hospice is basically it's a transition of care from a more active role of care to a more passive role, where you're just providing comfort measures. You're not specifically just okay, just say someone has cancer, God forbid, and it has not spread. Usually, we could maybe remove the cancer, or if need be, we may use chemotherapy or radiation therapy, trying to kill any cancers that go away. Anyway, that any cancers that might have escaped, and that's why we use chemotherapy and radiation therapy. Then, like, we can remove the cancer, and then you give chemotherapy and radiation therapy to prevent any kind of seeds of cancer from going anywhere. But what happens if those people who have cancer have metastasis and it just goes everywhere? Now they say it's inoperable and we can't remove it, but likely chemotherapy won't work. So in that aspect, what we'll do is we'll figure out, okay, people just say, well, we have to just let nature take its course, and that basically means letting the patient pass away. Like, there's nothing we can do anymore. We've gone to the extent of our medical knowledge. Like, once the cancer becomes metastatic, it's just sort of it's too far. And so, what is a patient left to do? Cancer now, it can get very painful and very it's a progressive disease. It's not an easy one. That's where hospice comes into play. Hospice is when hospice is when we have how would we say this? Is when we provide comfort measures. We're basically giving you, it's a transition from one form of care to another, where we're just giving you now comfort measures. Essentially, hospice is just providing comfort measures. Now, I will say this: if you decide that no, I want to do more aggressive treatment, you can leave hospice. Hospice is not some kind of death sentence, God forbid. Some people think that, oh, it's a death sentence, I'm stuck on hospice. No, you can just say no. You can tell a team you have full decision making capabilities, or if someone has lost that ability, the family can still make that decision. Saying, you know what, we don't want to do hospice anymore. We want more active treatment. So some people, and I will say this: if you're on hospice, you no longer go to the hospital per se. You are not going to go to the hospital for active treatment. You would likely call the nurse or the hospice medical director for the 24-hour 7 care that you will get. And this is done at home, or sometimes at a nursing home or what have you, or assisted living facility. So I, as a medical director, usually what we will do is we have these every 2 weeks. We will discuss who is a hospice patient, and we'll discuss are they eligible for hospice or not. And then every 2 weeks we recertify them. We try to figure out, are these people continuing to basically decline. And usually hospice is there for usually 6 months. Now, you don't have to be. Usually the idea is this person will pass in 2 months. In 2 months from now, or sorry, 6 months from now. I'm sorry. From 6 months from now, they'll pass. And so, hospice is there to provide that transition. Now, some people don't pass away in 6 months. That's very, very common, and it doesn't. In that case, we would just extend hospice. And I would like to share with you eligibility guidelines, like who is eligible for hospice or not. Sometimes that comes up. So usually what I do is there's a piece of paper I will get that we made. It's there. Here, let me show you. Well, I'm not sure if it's on the screen as well, but there are various eligibility criteria for you cannot use adult failure to thrive, but you can use cancer, dementia, there's heart disease, there's HIV, liver disease, pulmonary disease, neurologic diseases, and renal diseases. I'm not sure if you can see the screen, but what I'll do is this. Let me find this on the computer, on the internet, and I'll talk to you about these classifications, okay, or these criteria. Let me find you one. Okay. Actually, you know what? I'll show you how I found it. Hold on. Let me do this for you. Okay. So first, let me switch screens. All right. There we go. So all I write down is, look, hospice eligibility criteria. So say you are interested in hospice. So then I'll just go to images. And that thing that I used, let's see, this looks good. Let's see if this comes up, sort of. Or, yeah, this one. Let's see if this one, yeah, that's it. This is it. Okay, so these are Medicare guidelines for hospice. So, let's see now. Okay, sorry, I was getting a text from from a hospice. So I'm actually a medical director for 3 or 4 hospices. Anyway, so if we have someone who has, God forbid, cancer, we would look for these qualifications in order for them to be hospice eligible. Yeah. So we would find clinical findings of malignancy that are widespread and worsening lab status and evidence of metastases. Then we will look for a PPS score. That's a palliative performance scale. And if you sort of look sideways, you want less than 70%. So, oops, I don't want that. That's my palliative care. That's actually hospice talking. Oh boy. Okay, yes. Mark this right. Okay. So ambulation, the ability to walk around, is reduced. Activity, evidence of disease. They will say unable to do normal work, some evidence of disease. Self-care, like, you know, you can still take care of yourself, brush your teeth, comb your hair, all that kind of stuff. Go to the bathroom. Intake, that's your food, normal, reduced, and level of consciousness full. So you can see for cancer, and then refuses life-prolonging therapy, right, or continues to decline in spite of definitive therapy. So we would need all these, and this is not that hard to meet for cancer, frankly. And then we would start hospice, and then we would recertify you every couple of months to see if you're still hospice eligible. And cancer is very easy to be qualifying for hospice. And you can see right here that a patient has terminal illness with a life expectancy of 6 months or less. That's usually, but that's not always that's not like set in stone. Ooh, let me see if there's any questions. No questions. Okay, so let's go back. Now, renal failure is another reason you can be on hospice. So patients refuses dialysis or renal transplant and has a creatinine clearance. These are the lab values, and a serum creatinine of over. I can tell you that is very, very low. It's scary. And I can tell you that is very, very high for creatinine. These are basically lab values that we'll look for to see if someone has renal failure. And there's other supporting documentation. There's dementia. So that's like Alzheimer's and like forgetfulness. And for this, this is pretty. You have to have a 7C on the functional assessment scale, or the FAST scale. A 7C is right here. Ambulatory ability is lost. Cannot walk without personal assistance. So if you have other things like fecal incontinence, urinary incontinence, but you can still move around, well, you're not hospice eligible. So we're looking for loss of ambulation before we could start hospice for someone who has just dementia. Heart disease, you have to have pretty severe heart disease also. And these are the qualifications that we would use. And HIV is another thing we can do. Liver disease, pulmonary disease, stroke, or neurologic disease. So you can see there's a whole bunch of criteria that this is what I will use as a medical director to determine if someone is eligible for hospice or not. And I do this constantly. Like, this is constantly what I'm looking at. And I'm asking the nurses, what does that entail? And so what a IDG meeting is, that's the interdisciplinary meetings for, let me see if there's any questions. No questions. So interdisciplinary meeting is basically when the medical director, the director of nursing, let me switch here. 1 second, hold on. Yes. So An IDG meeting is the interdisciplinary meeting that all hospices have to do every 2 weeks to determine if their patients are still eligible for hospice. And that meeting includes the medical director, myself, a director of nursing, a chaplain, a social worker, and uh, usually those are the big four: medical director, nurse, chaplain, and a social worker. We need these four people constantly in a medical director meeting, in the IDG meeting, determine if someone is eligible for hospice. Sometimes we can start off with 1 or 2 patients, and some hospices are like that. They have maybe 1 or 2 or 3 patients, and some hospices have literally 40 patients, 43 patients of hospice. And we go through all of them. Then we have to make notes, and we have to determine who is eligible, who's not. We have to figure out who's coming up for recertification, and there's a whole bunch of guidelines that we have to follow for CMS, Centers for Medical Services, or Medicare. And it's I'll get called in the middle of the night. So and so has passed. I sign more death certificates than I can possibly. Like, I sign them every day, 1, 2, 3, all the time, constantly, for some patient, any patient, all the time. But yeah, that's basically hospice. If you have any questions about hospice, feel free to ask me. I do this all the time. This is literally, like I said, I'm a medical director for a whole bunch of hospices. But that was hospices, and I thought I'd now switch gears to the COVID-19 situation. Let's see. So for COVID-19, let's see what's happening in the world. So usually what I do is this coronavirus. And what is the COVID-19 situation? All right. Oh, did I switch screens? I don't know. I have not. Aha. There we are. Let's see. Is there any questions? No questions. Still that one viewer. Hello, viewer. Unless that's me. I don't know. Anyway, so we can see that there is 1.4 million. There is now 4,400,000 some odd people who have total confirmed cases. There are 300,000 deaths from COVID-19. The daily increases of cases are now stable at approximately, 80,000. The world has 80,000 new cases every single day. It's not good, and it's not dropping, and the world is just dealing with it, looks like. If we look at the United States, there is a general trend that is going down, but they are still the number one country that has COVID-19. And unfortunately, Russia is beginning to catch up, or what have you. There are now at 252,000 cases, and it's been a slight drop, not too bad, but it's still very high in numbers in Russia, and I would imagine Russia will maybe have higher numbers than all of the United States, which is pretty sad, I think. But I think that's going to happen in Russia. The United Kingdom is slowly paring it down, not like the United States in regards to total number of cases, but still. Spain is almost controlled it. Italy is, I would say, like I was estimating, Italy will have controlled this by the end of May. Middle of June, it'll be all gone basically in Italy. Brazil is still going high. France is dropping. Germany has dropped, and I've heard recent news that there's been a spike for a possible second wave, but we'll see. Turkey is also beginning to drop their numbers too, which is very nice. Iran it looks like there's almost like a second wave is happening in Iran. China is meaningless. Don't even waste your time. They're just lying. India, they're just going higher and higher. Also, just like Russia, as exponential amounts. Peru. If we look at Canada is beginning to pare it down slowly by slowly. There's 74,000 cases in Canada. That I can tell you, that's a lot for a country with only 36 some odd million. I'm Canadian myself, and I would say I've heard reports of provinces beginning to thinking of opening up, but at least they're doing much better than the United States, I would say. But the United States is, Belgium is doing well. Saudi Arabia is just going, just like the rest of, I would say, like Asia, like sort of like Russia. The Netherlands is dropping down nicely. Mexico is still going up. Chile is going up. Pakistan is, I don't know. I think they're going up. I'm not sure that's just a fluke or not. Ecuador is not enough data, frankly. Switzerland is almost complete, has basically controlled it. They've only had 33 cases yesterday, which is very commendable. Sweden, I don't like Sweden's approach of let's do whatever. I know they don't have that many cases, but um, I think with proper contact tracing, it would be much better than this. Um, let's see. Australia, I think, is basically, yeah. Australia is essentially defeated this disease. Let's see what Japan is doing. And Japan is also basically cured it. Not cured it, but meaning they've effectively controlled it. So let's see if there's any questions. No questions. Let's see. Hello. All right. Oh, that's those hospice thing they were talking about. Let's see if there's any news that we can talk about for COVID-19 or coronavirus. No, I don't want that. So, no. We don't have a master plan. They're saying the United States vaccine expert testifies the federal agents did not respond to alerts about mask shortages. Looks like barbers are illicitly cutting hair during the lockout in New York City. Michigan reports 1,900 cases. So I will say this. Let me go back here. Sorry. Okay. Oops, yeah, I was just yawning there. But I will say that it looks as though that the United States and most of the world want to restart before they're actively treating the disease. And I think that people's impatience is going to lead to more people's deaths. I don't think people are allowing enough time or enough measures to do what needs to be done. There are success stories such as New Zealand, South Korea, Australia, Japan, Switzerland, Austria, countries like that. They've done what, and even Italy is doing what needs to be done. But countries like the United States are not controlling things properly, and it's just going wild in like in Russia and South America and also in Africa. So I think that this will be there. COVID-19 will be there for some time. I don't know if sorry, when this is going to get over with, but I'm pretty sure that we're doing a premature opening, and then it's going to be, it won't get better until there's a vaccination. And even then with a vaccination, it's hit or miss. Meaning a lot of people in the United States are saying they don't want to be vaccinated. They think it's some kind of crazy conspiracy, or I don't know. Lots of people think there's all sorts of wacky conspiracies out there. So yeah, the end of the hour is coming. Is any questions? No. If you have any kind of questions, feel free to ask. I try to be here from 12:30 to 1 o'clock. I'll keep on doing it until maybe people eventually see that I'm there. Well, again, this is Dr. Abdullah. Thank you again. Bye-bye.